to have as much interactive time as we would like today, because frankly, I love the topic of blood pressure control so much, and I packed the agenda full of really great material, not only on the clinical side, but on the patient activation side. And we're very blessed to have patients actually with us today. Carla, are we going to be able to play that PSA now? No, you don't have it yet. Okay, so we will just play that at the end of the meeting. With that, I just want to say, for those of you who don't know me, I'm Hattie Hanley, and I run the state's Right Care Initiative. We work statewide as well as in 3 major metro areas, and we would love to see the capital region here be a major pilot for reducing heart attacks and strokes. We've got great partners with us in the room today, and with that, I'd like to ask all of you to go around the room and introduce yourselves, starting with our co-chairs.
Hello. Sorry, speak loud without the microphone. I'm Pamela Laesch. I'm a regional medical director for Health Net for Northern California, and I'm one of the co-chairs here for the Right Care Initiative, and have been since January.
Good afternoon, thank you for being here. My name is Darrell, and I'm the other co-chair of the Capital Region Right Care. And I've been here since the beginning, and really excited about this presentation.
One of the things that's important to making progress here is getting to know each other. So as each of you do participate in the meeting, please say your name and organization, because it takes a few times to get to know each other's names and faces.
Hi, my name is Mary Ferguson. I'm the Chief Medical Officer for Health Services Advisory Group, the Medicare Quality Improvement Organization for California.
Jerry Cheppy, California Chronic Care Coalition.
Chuck Wiesen, Health for All, and FQHC in Sacramento.
Lisa Fulber, CEO of the CMA Foundation. Laesch, California Department of Public Health.
Janet Bates, California Department of Public Health Chronic Disease Control Branch.
Swati Ostori, Northern California Medical Director for Aetna.
Coralie Chan, Kaiser Permanente Community Benefit National Officer.
James Palmieri, California University College of Pharmacy.
Hi, Juliana Burton, Assistant Chief of Pharmacy at UC Davis.
Hi, Gilbert, UC Davis Medical Center.
Warren Barnes, UC Berkeley School of Public Health at Grace Presbyterian Church in Sacramento.
Don Hubbard, Chief Medical Officer, Western Health Advantage.
Hi, Chris Wood, I'm the Administrator of the Dignity Health Neurological Institute.
Hi, Joyce Higley, Director of the Heart and Vascular Institute with Dignity Health.
Marilyn Stebbins, UC San Francisco School of Pharmacy.
Hi, Ruby Lynn, Research Assistant for the Right Care Initiative at UC Berkeley.
I'm Bill Simon. I'm a Medical Director of Sac County Medical Centers, and I'll be your distinguished speaker today.
Carla Brady, Right Care.
Darrell Flynn, Sacramento Family Medical Center.
Liz Helms, President CEO of California Chronic Care Coalition.
Latanya McDaniels, and I'm also with Sacramento Family Medical Center.
Debbie Nixon, Health Services Advisory Group.
Hi, Vicki Williams, American Heart Association, American Stroke Association.
Hi, I'm Jan Vandermeef, Ambulatory Care Management Director for Sutter Health.
My name is Kimberly West. I'm a family medicine physician with Sutter Health.
Good afternoon, everyone. Desiree Backman, Chief Prevention Officer with the California Department of Healthcare Services.
Hi, Neil Kohats, Senior Medical Director at Department of Healthcare Services.
Hello, I'm Diane Littlefield, Vice President of Programs and Partnerships here at Zero Health Foundation. Welcome.
I'm Joan Wardland, recently retired UCD nurse specialist in diabetes, and I'm here today representing as vice chair of the California Health Collaborative. I'm vice chair of the board.
Dan Tuberty, pharmacist as well as account manager with Boehringer Ingelheim Pharmaceuticals.
Did we get everybody?
So we're going to get that. The mics aren't working on the podium, so we're going to.
Pass those around. Thank you. Yeah. Thank you all, and again, very exciting to be here and to continue our activity as Right Care. So I wanted to sort of step back a little bit because you know, we've been meeting almost 2 years now, and since 2012, and talking about improving cardiovascular complications in this capital region, and really sort of letting the swords at the door and sharing and collaborating across the health systems and with the county and with the community clinics, which is very exciting to us. But what I wanted to do is take us back a little bit because, you know, one of the key areas that we have been talking about and we want to focus around in this presentation is around managing blood pressure, which is a big, big challenge for us. And so I wanted to take us back to what started Right Care in the first place. And really one of the major initiatives that the federal government put on is the Million Hearts Campaign, which its goal when it was started a few years ago was to prevent 1 million heart attacks and strokes in the United States within 5 years. And again, you know, just reminding you of the fact that this is a key reason why we've been together is to try to collaborate at a higher level and across our organizations. And just to remind you that when we started talking about this back in 2012, fewer than half of Americans with diagnosis of hypertension have it under control. And again, huge numbers that we're talking about. 67 million adults with hypertension, literally almost a third of adult Americans. And those who were uncontrolled, more than 50%, about 36 million at that time. And of those 36 million, you know, we are aware that about 60 million is aware and treated, but is not under control. And then there's about 14 million that is really unaware that they have hypertension. And we need to reach out to that population because many will be coming in with all the ravages of uncontrolled hypertension. And there's an opportunity for us to address this issue. This is again from Right Care, from Million Hearts. And the key piece of this, the message that I wanted to send out to us is it doesn't take much to have a big impact. Small reductions in reducing systolic blood pressure can save many lives. So as you can see, this graph shows that based on prevalence, a small reduction in blood pressure, if you see the percentage reduction in mortality for strokes, can be huge. So two reduction millimeters of mercury blood pressure control will result in about 6% reduction in mortality from stroke and 4% from heart disease. And a 5 millimeter reduction will have some major impacts, so greater than 14% reduction in stroke and 9% in heart disease. And along with that, of course, for those of us who are in large systems and integrated systems, this data is very compelling that if we look at medication adherence and we increase the adherence among hypertension in particular, and along with it hypercholesterolemia, we see that if we increase medication adherence by percentage-wise, and you see the decreasing trend here that really results in significant hospitalizations, and of course, along with it is some really significant cost controls with, you know, upwards of in the neighborhood of $10,000 in total cost of care by having medication adherence improvements. So the challenge is tremendous, and really for us, it's really how do we do it, and how do we facilitate you know, this process of improving both the identification for populations who are at risk of hypertension, and and then putting the pieces together to result in medication adherence and control of blood pressure. So, we know the drill. We got to identify those who are diagnosed and move the treated to controlled, work on self-management and drive measurement and reporting, which is key, and this is what we are all about here, and educate and activate about things such as high sodium intake and other things that result in improved blood pressure control. With this improved control, we'll see that, at least for the nation, we'll address those 14 million that are undiagnosed, move to treat those 16 million who are diagnosed but who are yet controlled. And again, we have some huge numbers here that we at least have a small part here in Sacramento. So what I wanted to do is to see if we could get a commitment, and I know this is huge, but really asking for our partners that we at least consider adopting one plank and measure our pressure down, which we're going to hear from Dr. Laesch, who's going to give us an overview on this excellent program. So it's a call to action, and I hope that at some point we can discuss maybe later on in the meeting, how do we do this if we really want to do this. So now I'm going to introduce Dr. Laesch, my co-chair, who is going to help us run through this program, Measure Our Pressure Down.
So before Pamela starts her presentation, and Carla's going to be working on getting her slides up, I just want to point out that in your packets here, behind your agenda, right behind your agenda, you have the Right Care Initiative brief, which has the triangle on it of the promising interventions that we've been trying to spread. Many of them gathered from the major health systems that are present in this room. And the difficulty is getting it out into primary care. You also have our data brief, which Ruby Lynn helped to prepare at UC Berkeley, which shows that Sacramento Valley has a much higher incidence of heart attack and stroke than the rest of the state, so we need to do a special push here. We also have data that shows that the health plans of California have all improved their blood pressure control better than the nation. And we also have data from the Office of the Patient Advocate showing control of blood pressure for people with diabetes in Sacramento. So you have to be worried about these people in what we call the white space on this gold bar chart. Because blood pressure is such a silent killer, as is hypercholesteremia. My own mother died of a stroke, of uncontrolled high blood pressure. So when I see all of these patients out here with uncontrolled high blood pressure, you can bet I'm going to be working to make sure more of those patients get into control. So with that, I'll turn it to our wonderful co-chair, Pamela Laesch. She's not only a medical director with HealthNet, she is a former emergency room physician who sees these patients that come in with the silent killers who have unnecessary devastation to their lives.
Right. Thank you. We're going to do a quick switch of the agenda, though. We were able to pull up the PSA, so we're going to kick it off with a video so we can kind of frame everything up.
Do we have sound?
Just another number, right? Think again. It can mean all sorts of bad things. Swimming is great, but swimming with 140 sharks is a bad idea. Ever tried to write more than 140 characters in a tweet? Good luck. Drinking 140 proof health. It's also flammable at room temperature. Ever been on a bus with 140 school children? You can be scarred for life. Gain 140 pounds and get ready for serious health problems. And you might need a new scale. 140 is too much on my head, and it's too high for blood pressure. A blood pressure reading of 140/90 or higher means you're more likely to have a stroke or heart attack. Visit heart.org/HBP to find out more about the
the Heart Association has developed some very, very impressive materials. Sorry about the logistical issue there. And Dr. Pamela Laesch is going to introduce a really practical approach to for people in the region to use.
Right, thank you. I'm going to kind of kick off the overall description of the Measure Up Pressure Down program as a preamble to Dr. Simon, who's going to come up and give us his experience of actually going through the program. So we thought it would be better for us to just kind of give an overview of the program so everyone's aware of what it is and then hear some real life experiences from it. So the AMGA, which is the American Medical Group Association, was kind enough to give me these slides to help discuss the topic today. So just basically, this program was developed by the American Medical Group Foundation, which is actually the charitable arm and the learning and research arm of the American Medical Group Association, which is a very large trade organization that has been supporting and representing large medical groups and healthcare systems since the 1950s. So that's who came up with this program, just to give them credit where credit is due. So a few years ago, the AMGF, which is the charitable arm of the organization, got together and said, you know, we need to come up with a national, multi-year campaign to address chronic care conditions in the United States. And you know, their first idea was, let's go ahead and do the hypertension piece. Basically, for many years, the AMGF has been doing this on a very small scale. So they have what is called learning collaboratives. A lot of you may be familiar with these, where they take 15 to 20 medical groups and they share best practices, kind of similar to what we're doing here. Well, they had two campaigns, one in 2006 and one in 2008, where they had 15 to 20 groups who focused on hypertension. And what they found in these groups is with the best practices that were learned and shared, they improved by over 80% their blood pressure control. So they said, let's take this, let's make this national, and let's make it a multi-year campaign. And as Dr. Arevalo was saying earlier, you know, 68 million Americans have high blood pressure. That's 1 in 3, and about 20% don't even know they have it. So this is huge, huge area for impact, you know, given the fact of the contribution of hypertension to stroke and heart attack. So the campaign set out with 2 goals: primary goal, secondary goal. The primary goal was to have 80% of the members that were enrolled in this program be at blood pressure control by 2016. The other primary goal was to have 50% of the AMG's medical groups join into this program by at least doing one of the planks, which I will go over here in a few minutes. Their secondary goals were really to engage and get the patients involved, because they don't spend their entire lives in the doctor's offices, as the patients here can probably attest. And so how do you put that into the general public's education and really get the public engaged into controlling blood pressure? So now I'm going to kind of start going over the campaign planks. So the campaign planks, there were 8 of these that were developed, and these were taken from these previous learning collaboratives that I spoke about that had taken place in the early 2000s. So basically the campaign goal, let's get 80% of the patients to have blood pressure control, and these are 8 best practices that we think that will help people get there and has been proven. So the first 5 planks, which are at the top, and I'm sorry if you can't see this very well. Am I too loud on this microphone?
Not
loud. Sorry about that.
It's perfect.
I have a lot of voice, so I apologize. Are really the easier planks, so to speak. They don't involve a lot of extra resources, infrastructure, funding, etc. Something that really is actionable. And then the bottom 3 are more secondary goals. They take a little bit more infrastructure. So basically, the AMGA asked, you know, will all of their member groups do at least one of these planks? And some have actually taken on all 8. And Dr. Simon actually took on 7 of them, all 8 of them. So he will be able to tell us in detail about them. So I will give you a little bit of an overview quick about what the planks are. So the goal of the first plank, if you can't read it, says to direct the care staff, make sure they're trained in accurate blood pressure measurement. So basically, you just assume everyone knows how to measure blood pressure, but they don't. Case in point, when I was in high school, they decided to do our sports physicals in the middle of gymnastics practice. Every single girl on my team had high blood pressure because they pulled us right out of practice and took our blood pressure. So, just a little side note there. Anyway, so even at 16, I thought that didn't really make much sense. So you can't just assume everybody knows how to measure blood pressure accurately. So you actually came up with, let's train the staff, and every year let's remind them, let's recertify them, let's make sure that they haven't forgotten. So that's the first plank. The second plank is to make sure that each medical group adopts, it doesn't have to be the same guideline, but adopts some nationally recognized guideline on what is controlled blood pressure, how do you control it, an algorithm, a protocol, etc. And I will go into it later, but there are some examples of some of the tools that other groups, such as Kaiser Permanente and Short-Reach Daily out in San Diego, have adopted in the toolkit. The third plank is that blood pressure should be addressed for every patient at every visit, no matter why they're there. So if the member has blood pressure and they're going into their primary care physician for a sore throat, or ear pain, or a sprained ankle, blood pressure should always be taken. It should always be addressed if it's abnormal. The fourth plank is all patients that are not at goal should have a follow-up visit within 30 days. Now this is somebody who is newly diagnosed blood pressure problems, someone who has recent change in medication for whatever reason, whether it's intolerance or not effective, or anyone who's not at goal. And there are several different ways you can do this. Some groups adopt medical assistance, having the member come back in, take the blood pressure, and notify the physician. So there are several ways to do this. And then the fifth primary one is the prevention, engagement, and self-management program in place. So this takes a little bit more effort where you're actually developing educational tools for the patients to take home, blood pressure logs, best practices on nutrition, etc. So if we move into the secondary goals, another thing would be to have a registry, so you can identify your patients that do have high blood pressure, so that one, you can check through your EHR to see, are they coming in for their checkups, are they missing checkups, are they filling their medications, and help to engage and identify them, and also be able to follow to see how well they're doing. The next secondary value-added plank is that all members should be trained in the importance of the blood pressure goal. And that is just really to have that at the forefront of everybody's mind every day when they're seeing people in the office. And then the last one is to get all the specialists involved. So to get your ophthalmologist to take your patient's blood pressure when they come in, or ear, nose, and throat, or GI, and if it is out of control, to make sure that that member gets back to their primary care physician or their cardiologist to have this managed. So those are the planks, kind of in a very big overview. So I have a couple of examples here on what some different groups have done. So Colorado Springs Health Partners, they decided to take on plank 1, which is one that's very common for people to take on, since it's a very simple one. And so while they were trying to train, they realized, well, our blood pressure cuffs are kind of an odd place. It's cold in Colorado, people are showing up with their jackets on and getting their blood pressure taken over their sweaters or their jackets. So they found several different ways to help improve this blood pressure accurate measurement. So they also found that some of the blood pressure cuffs were far away from where the chairs were, so they rearranged some things. So even just taking an inventory will kind of help. So they also developed this little chart that goes up next to the blood pressure cuff area to remind everybody on the proper blood pressure. Plank 4, which is what to do when patients are not at goal.
Would you back up to that slide and really go through it, because I think that this is it is not how it's normally done. So I'd really like you to
No
say
problem.
how that is.
Sure. And this is found in the toolkit. So basically, make sure you use the right size cuff. 10 minutes left on that, 10 minutes. 10 minutes?
9 minutes left.
Okay, thank you. To make sure you use the right size cuff. If the cuff's too big, the blood pressure is going to be too low. If the cuff's too small, the blood pressure is going to be too high. Also be sure to ask patient which arm, because certainly people on dialysis or people who have had mastectomies or strokes shouldn't have their blood pressure taken on that arm. Be sure that the arm's at heart level, and this is one that you don't see a lot, with the palm of the arm upright. A lot of times you'll see people with their arm hanging down. Make sure the back is supported, the legs are uncrossed. Avoid having the patient talk, which a lot of people do because they're sitting there in awkward silence, so it's nice to remind them not to talk during that time. Be sure you record the exact numbers. And again, wait 5 minutes before you take the blood pressure. It kind of goes back to my grabbing someone out in the middle of gymnastics practice. They may have just walked up a flight of steps or come running in from the parking lot. Again, these are all in the toolkit. This is just an example of something that somebody came up with. So Kaiser Permanente, as far as bringing people in, if they haven't been at goal, they actually developed a medical assistant program where they had the medical assistants bring people back, take the blood pressure, and then go find the primary care physician so he could or she could then help direct the care and decide if they needed to see them then or they could do the adjustment of the medication by their protocol. When they did this, their control rates improved from 44% to 87%, which is a huge improvement. And yeah, very, very, very good. And actually, they did publish this in JAMA, so it actually was published in the journal. The improvement that they made. This is just an example again, which would be in the toolkit of kind of their documentation policies and spreadsheets, etc. So this is another one for 5, which I think after talking to Dr. Simon and may go into this more is maybe more and more challenging one of the planks is the prevention, engagement, education for members, because this would take a lot of education materials, a lot of training, etc. So Billings Clinic in Montana, they did a report card. And so on this report card, they have the patient's most recent blood pressure measurements, their weight measurements, gave them tips on weight loss and diet and stress management, etc., to really help engage them, and they share these with the members when they come in so they can see the progress they're making as well. Henry Ford up in Detroit also made a whole suite of education materials which they have been sharing with patients as well on the improvement of blood pressure and ways to manage it and how they're doing with their report cards. So this is what I was talking about earlier. All this information can be found online at the Measure Our Pressure Down website, which they've developed a provider toolkit, and it goes through each of these 8 planks, actually quite detailed and with a lot of examples. So it's a really nice resource. We just don't have the time here to go through today. There's some other resources as well. They have a Facebook page, Twitter, Flickr. There are all several different ways to become involved on this. And this is just real briefly, this is only 1 quarter of data that they were able to provide for me, but in the first quarter, Q1 to Q2 in 2003, they had an absolute increase of 2.8% blood pressure control, but 4% relative improvement, which equates to 30,000 patients that now had blood pressure control in the first quarter. So to put that in real numbers. So with that, I'm going to turn it over to Dr. Simon, who's actually going to tell us his experience going through this program. A bit of a whirlwind overview, but hopefully you'll gain more knowledge and get in depth. Thanks.
Can you hear me okay? Okay. So how about this? Okay. So let me just start by saying that SAC Family is a Medi-Cal-focused organization, and we've been doing this for quite a while now. So we've been in the Medi-Cal field for 25 years. That's 25 Medi-Cal years, which is probably longer than a dog year. So this is one of our clinics. This is our clinic in Del Paso Heights, and this was a clinic I developed myself. The city of Sacramento gave me the land for $1 and gave me the money to build the clinic. And I built the clinic, sold the clinic, and with the money that I'd get out, built 2 more clinics. So we now have 8 clinics, and we take care of between 30,000 and 40,000 patients. It's hard to keep track of the fee-for-service patients, but we have about 30,000 managed care lives, all Medi-Cal. This was our mission that we began with 25 years ago, and we have made all of our decisions in response to this mission statement. So, and it continues to this day. In many ways, it's the same mission as the mission of best care practices, best practices, in that we rely upon evidence-based information rather than community standards of care, which aren't always the best. So, for these 25 years, for the first 23 of those years, we lived in relative isolation as a Medi-Cal-focused organization. We were isolated from the rest of the medical communities, and we evolved and mutated systems that would work for our patients and for our very limited budget, not knowing what was going on in the outside world, until one day I was invited by Liz Helms to take part in this program, and And this was my coming of age, learning about what's going on in the outside world, and my invitation to the mainland of medicine. So for that, I owe a great debt to Liz. Well, from there, I met all kinds of people and saw all kinds of great things going on, and much of what I saw was not applicable to the Medi-Cal practice or Medi-Cal world, which is a different world. It's a parallel universe, and it's not the same as the commercial world. But when I saw the Measure Up, Pressure Down program, I said, I can do this. This doesn't require robots. This doesn't require large grants. This just requires a commitment to carrying out these clinics. So with the aid of Health Services Advisory Group and with Chronic Care Coalition and Best Practices and American Heart Association, we got started using all the toolkits that Measure Up, Pressure Down provided. So why hypertension? As you know, it is the common denominator for the major diseases, heart disease and stroke. It's very prevalent, as you saw from Dr. Darrell's slides. Very poor control rate, as you saw. And getting control has a beneficial effect on mortality. So it seemed like a logical thing to approach, and one that we could approach. We weren't lacking resources to tackle this particular problem. So you see this slide a few minutes ago, this slide is very impressive because it's what I use to show my medical assistants that even a small gain in blood pressure control has a gain in mortality, decreasing mortality. So I'll go through the planks very quickly. The first plank was teaching your blood pressure measurer to do it correctly, which was a very difficult task. And I took this upon myself personally, and I went to each of my clinics. There are 8 clinics, and I taught each of the medical assistants how to take a blood pressure. And amazingly, they all took it different ways. And Dr. Laesch showed you the 5 key points of taking the correct blood pressure, but there were 32 points in taking the blood pressure correctly. And I go by each of my clinics, I listen in to the rooms, I hear them talking to the patients. Have you had a cigarette in the last 5 minutes? Do you have to go to the bathroom? They're asking all the right questions. These are among the 32 points that have to be asked. So they're doing it right. So that was easy to do, but it took persistence. And then once they learn how to do it, they have to be taught again and again and again. But that was a plank that was doable. The plank, then selecting a set of guidelines was also very doable. We just used the JCN guidelines, JCN 7 guidelines, which the American Medical Group Association is still using JCN 7. They have not yet adopted 8, which is somewhat controversial. So we're still staying with 7 for now. All of my providers were easily convinced that this was a worthwhile program, except one. And one said this is not going to work because the patients are non-compliant, that they're not going to take the medicine, they're not going to come back, that it's not going to work in our population. So interestingly enough, his patients had no improvement over the 15 months. The only one whose patients stayed at the same rate from the beginning. So it was a self-fulfilling prophecy. So we had the toolkit, we did quizzes, we accepted the guidelines, and then we went to the non-clinician visit after 2 weeks. And prior to that point, we were doing every 3 months for uncontrolled hypertensive. We went to every 2 weeks. And sure enough, the patients, most of them came back in 2 weeks. And we were able to take the blood pressure, and then after the medical assistant takes the blood pressure, she then waits outside the door of the provider and has a 30-second conference when the provider leaves the room. And she discusses the blood pressure, and he discusses, or she discusses what the next up titration is going to be, and the patient is then sent home with a new regimen and to return in 2 weeks. Every 2 weeks until the pressure becomes within the goal. So that worked very well, and it worked very well primarily because my medical assistants were so incredibly motivated to do this. In many ways, a Medi-Cal focus group lacks many resources, but in one way we have a superior resource. We have medical assistants who are highly motivated to do good for the patients in their community. They are our strength. Many of them, most of them live in the community where the clinic is and know the patients, go to the same churches as the patients. Is that true? I think that's true. They go to the same church, many of our patients know them from church. Many of our medical assistants were formerly patients of ours, and most of them have family members who are still patients of ours. And a few of them, of our medical assistants, were children who I took care of as their pediatrician. So I have a very close connection to SAC family and a very close connection to the community. So that's our bridge. It's our medical assistants. Our clinicians know what to do, but it gets done by the medical assistants. So, so we couldn't get blood pressure cuffs to do home monitoring. We attempted to do home monitoring at the local drugstores, and some did and some didn't, and those who didn't bring the results back to us. So instead of that, we just said, come in whenever you want to come in, we'll take your blood pressure for you. So we'll do closer monitoring in the clinics. So we had the one physician who pushed back, and I mentioned to you that
That's a really nice contrast, Dr. Gil.
Yeah.
I think of you as Gil, Gil Simon. Because I won't name the medical group, but because my mother had died of uncontrolled, asymptomatic high blood pressure when I was 15 years old, I've always kept really good eye on my blood pressure. I have a home blood pressure monitor, thanks to Liz Helms. She gave it to me for my birthday one year.
Only because you didn't have one.
Yeah. Well, I've learned a lot from the patients, shall I say. But my own medical group, when I went in to get a lab draw for my cholesterol, I said, hey, while I'm here, while I'm waiting, can I just get my blood pressure taken? And they said, no, not without an appointment. I thought, this is ridiculous, right? You've got all these people sitting around, we've got this great opportunity, and I'll just lay that out there. I think that that medical group should reconsider, and all medical groups should reconsider the accessibility of blood pressure monitoring, like what Gil Simon is modeling for us.
Well, anytime a patient seeks out any medical attention, we're not allowed to deny it. Our role is to encourage them, not to discourage them. And as far as one of those plans was recording blood pressure at every visit, we've been doing that for years. We have a 99.99% blood pressure taken with each visit. And we know that because of HSAG reporting that to us. So again, I didn't know that, but I don't anything about what we're doing, but HSAG let us know that we're 99.99%, which means probably one every year left to get a blood pressure taken. So as far as, I think I'm obligated to go through JCN, or JNC 8 at this point, because that's part of one of the questions you have to answer. So where am I? Oh, I'm going to yours. I'm sorry. Okay, so this is what happened with this, the Joint Commission. They changed guidelines for people over age 60. They raised the limit to 150 from 140. And they took away the special requirements for diabetics and people with chronic disease, kidney disease. So that's the major change. And they made changes in selection of the first starting medication, making African Americans not take the ACE inhibitors, but making those with chronic kidney disease take the ACE inhibitors as a starting treatment. So probably everybody here knows more about treating high blood pressure than I do. So I'm no one to teach this subject. What I know is how to activate my staff and how to get good results. So that's it for JNC 8. So, as I said, we had virtually all of our patients came back for the 2-week check, but not all. And if they don't come back for the 2-week checkup, and it's by appointment, we don't let them off the hook. They get a phone call that day from the office manager. And this is what she says. This is the script they all use in their own language. This is what they say. Can you come back? You missed your appointment. Can you come in today? If not today, can you come in tomorrow? Not tomorrow, can you come in the next day? We make them know that we want them to come back. And then if they get any resistance, we then begin to explain why it's so important in increasing levels of scariness. So we tell them that every point that they lower makes them that much healthier. We tell them 20 points off the top number, which is a solid number, will cut their risk in half of cardiovascular disease. And if they're still resistant, we then hit it with, if your blood pressure stays where it is, you have 1 chance in 6 of dying in the next 2 years. And that's pretty truthy. It's what Dr. Doodle showed in his slides, that the high-risk patients who above the age 55 will not survive beyond, 17% will not survive beyond 2 years. So that's usually that's our final weapon. So here are the results. This is the result from the one provider who said, "This sounds great. Let me add it." And she began with 30%, and by 15 months she was at 75%, which was just a spectacular improvement. She was very enthusiastic. She accepted the program, and she's very closely connected to the patient. She knows them all for many years, and her medical assistant has been with her for the past 12 years. So this is a very effective healthcare team, and that's what it takes. So, that's me. This is the overall. This is overall. We began at 46%, and by the first quarter of this year, we were at 64%. So we have a long ways to go, but I did notice that when Kaiser began their program, they began at 44%, a little lower than we began, and at the end of their first year, they were still in the 40s. So we're ahead of Kaiser. So, but I thank Kaiser for all their protocols and for sharing all the information with us. It's all part of this process. So, a few case studies just to illustrate what we did and what the problems we encountered in dealing with our population. So case number 1 is an almost 70-year-old Latino gentleman with diabetes, chronic obstructive pulmonary disease, hypertension, obesity, and intolerance to ACE inhibitors. And he came in as a walk-in patient. So as many of our patients walk in. We're not a walk-in clinic, but many of our patients are walk-in patients. So again, we don't discourage anybody who wants healthcare, we're going to offer them healthcare. But we try to do it by appointment. So he walked in with a blood pressure that was elevated, 176/88. He was off medications, also pretty common in our population. And that's because Medi-Cal is a month-to-month open season plan. And if they're off medications, they're off Medi-Cal, they're on their own. So he came in on his own off medications. So the provider, knowing this story, obtained a prior authorization to use Mycardis diuretic. After a few days, it was approved, and the patient came back again exactly 2 weeks later. And the blood pressure had come down from 176 to 156. He increased the dose, doubled the dose, and the next visit, blood pressure was under control. So this case illustrates the walk-in patients, the off-medication patients, and the difficulty in getting combination medications. This next case is a case of a woman with hip pain. Her issue was pain. That's why she came to the clinic on a regular basis. She was seeing a mid-level, and each time the visit occurred, it was spent dealing with the issues of pain. Never got to the issue of high blood pressure. So the pressure remained high despite countless visits, 8 visits, with very slight changes in medication. This particular mid-level then left. The patient was turned over to an internist who recognized that this patient was undertreated, added lisinopril, and the very next time the pressure was under control. So this was a more aggressive approach that needed to be taken. So what worked and what didn't work, lifestyle changes, teaching lifestyle changes didn't work. We were unable to get home blood pressure monitors. We don't have dietitians available to ourselves. Our patients are not free to exercise. They don't belong to health clubs. And then for many of our patients, it's dangerous to even walk outside on the streets. So it's difficult to teach lifestyle changes in a very resource-deprived environment. And our patients have many comorbidities, many of which are in poor control. So, which brings us to the next topic, which I really want to really spend the rest of the time talking about, which is health literacy. Now being recognized as a new vital sign, and probably the most important factor that we have to confront. It's defined as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services that they need to make appropriate health decisions. This is not literacy. Literacy is the ability to read. This is the ability to acquire, process, and understand. And from the AMA report, poor health literacy is a stronger predictor of a person's health than age, income, employment status, education level, and race. So this is plank number 5. We have to walk this plank if we're going to get past the barriers to changing lifestyle. So here's the impact of low health literacy. It's very costly. Those with low health literacy cost 4 times as much as those with high health literacy. It accounts for $50 to $70 billion a year, or 3 to 5% of the total cost. So you'd think that with that degree of cost, that there'd be some investment placed in this area to get a big return. Hospitalization rates are 50% higher. They make more medication errors, less likely to comply with treatment, and lack the skills needed to successfully negotiate the healthcare system. So this is a very costly problem. This is what our written instructions look like to many of our patients. Very difficult to understand. But for those who have no reading disabilities, written instructions work fine. For those who have language problems, reading problems, dyslexia, this is what it looks like. And we had a patient who we sent for an x-ray. He went to the hospital for this x-ray and walked through the hospital looking for the x-ray area. And all he could find was areas that had radiology suites. There was no x-ray suite, just radiology. So he looked and looked for a sign that said X in it, and he found one that had X in it. It was the exit. And he left. So this is a real issue, and we have to be aware of this. So health literacy is broken down into 4 categories. High health literacy, proficient, intermediate, and basic and below basic. So proficient, intermediate, basic, and below basic. And you see below basic, if you have difficulty reading simple instructions, such as what's on the prescription label, take this medication twice a day, means morning and evening. It doesn't mean take 2 pills at one time. All this has to be clearly explained, and this is who is at risk of having low health literacy. People over 75. These are the ones who have Medicare-insured patients who have an average of 3 chronic diseases and taking an average of 5 medications per day. So it helps having a high level of health literacy. If you look at it by insurer source, employer-provided patients, such as the Kaiser patients, only 7% are below basic. But if you look at the Medicaid insured and the no insured people who will soon be Medicaid insured, it's almost half. who have low health literacy. All of this becomes a big problem. So this is what needs to be done, and it needs to be done by people who have a great deal of influence and money and power, promoting universal access to health information, address health literacy as a part of the disparities initiatives, encourage public insurers to model improvements, and promote educational standards for all. All of this will take time and money and investments. But here's what we can do as providers, as clinicians, with our patients. We can speak to them in plain English. We all know how to speak in medicalese, but it's not easy to speak in plain English, especially after you've had many, many years of training to speak one particular language. When we enter the room, we can sit down instead of stand. We can get at eye level with our patient and make the patient comfortable, and we listen to them, what they have to say. We have to ask the patient how they want to be addressed. Not every patient wants to be addressed by their first name. It's disrespectful if they don't want to be addressed by their first name. So we ask how they want to be addressed, and we come prepared for the visit. It's also disrespectful to come into the room and open up the chart and read and say, why are you here? We should know why they're here. And that normally takes place outside the room. And this is the most important thing, we don't end the visit until we're certain that the patient understands what the instructions are. And you don't get to that point of certainty by asking them, did you understand what I have to say? Because they'll say yes, for the most part, to avoid being embarrassed. You can't ask that question. You have to ask them to repeat back to you, teach it back to you. Tell me what you understood about today's visit. What changes are we making today's visit? Tell me in your words what we're doing today. And if they don't give it back to you the way you gave it to them, the fault is not with them, the fault is with you. You did not explain it well enough. It's not their problem, it's our problem. Communication is a two-way street, and we have the task of communicating effectively. And that means being certain that the patient leaves the office knowing what was said, knowing what the changes are, and understanding it thoroughly. And so there are very complicated ways of testing health literacy, very complicated ways of working on this, but here's only one way that I like to say. Listen, just listen to your patient. Be sure that they do more talking than you do, and if you find that you're doing more talking than they are, then you're a lecturer. You're not really listening to them. So a good doctor listens. So with that, I'd like to introduce a few of our guests of honor, Latanya and Darrell, and who wants to come up first? Latanya.
Welcome, Latanya.
Thank you, Dr. Simon. As you all know, I'm Latanya McDaniels, and I received the opportunity to participate in the program several weeks, and this program changed my life. I'm going to try not to get emotional. My grandmother suffered a heart attack when my daughter was 4, and 3 years ago, my mother suffered a stroke. So the possibility that I could have one or both of those things happen to me was very real. I didn't start out with being in the program. I actually am the outside event planner at my church, and so I was contacted by Aaron to engage services through the church. So I happened to be there to open up the church and to welcome the staff, Liz and Debbie and Vicki and everyone who was there to participate. And Aaron was kind enough to ask me, hey, you look a little frazzled, would you like to get your blood pressure checked? And I figured, yeah, sure, I'll do it. I've been working out. I had recently, had changed my lifestyle and I joined a gym. I'd lost about 22 pounds, so I figured, okay, I'm gonna get really good results, and I'll give myself a little pat on the back. And when she took my blood pressure, I was overwhelmed. It was 174/96.
Oh dear. And you're here.
So after I pulled myself together, I took a break. I went and I prayed because I knew it was only by God's grace that I was still here. I called my mom and I asked her to please come and hear what the speaker had to say. So with the help of Vicki and Dr. Simon and all of the other people who participated, I realized that it wasn't just cutting my calories and exercising. I had to take control and be an active participant in changing my life. And so I am so thankful for what you've done in the community, and I'm so privileged that I'm able to stand here and tell you that as providers, you make a difference. The programs that you bring, the awareness, letting people know that they have to be actively involved in managing their health and making wise decisions, that it will be the only way. So I thank you for the opportunity to speak. I'm sorry, I didn't mean to cry, I'm not a crier. But this class has been life-changing and life-affirming because I now have the tools to be better and have a better tomorrow. And I'm no longer one of those health illiterates. And it's because of this program, so thank you.
So Latanya, I have to say that in the last 2 years, we've many times said, we need to take it to the community. We need to get it out into the churches. And thank God that somebody got it to your church. Thank you, Health Services Advisory Group, American Heart Association, Chronic Care Coalition for taking it out into the community. And we in this room have an obligation to figure out how to do that better. And Kai-Ying is leading that effort for Sierra Health Foundation. Kai-Ying, why don't you stand up so everybody knows you?
So I failed to explain what the program was. The program is called Check, Change, Control, and it's a creation of the American Heart Association and HSAG. And we did this pilot study in Sacramento near one of our clinics. And it was all done through the efforts of Debbie and those who she could rally to join the group. So it was very successful and is now going on in other parts of the state. So check, change, control. Darrell.
Good afternoon, everyone. Check, change, and control. I learned a lot there.
Can you get closer to the mic, please?
I learned a lot there, check, change, and control. I learned how to check my blood pressure, control my eating habits, and change the way I'm living. So actually, coming to Sacramento Heart was a blessing for me because I was looking through Sacramento for a doctor, and I kept going to emergency rooms, and I said, well, let me call. So then some kind of way I got the number to the medical center there, Sacramento Medical Center, so I made an appointment. It was like 2 months out, and I said, well, I'm waiting out though. So when I went, I liked the environment. I liked the way the people treated me and stuff. So then I got a call from Erin one day. She says, how would you like to come to a study? I said, oh, what is it? She said, we're just going to exercise and eat lunch. I said, okay, cool. So I go and first day I was like, I enjoyed it. I enjoyed what we did, the exercise that we had, the encouragement, and just the way to just learn how to read labels about the salt intake we take. You know, just the different way to change my diet from the way I was eating. You know, eating late night salt and hot sauce, and all it has a lot of high salt content. I learned now not to eat with salt. I learned how to not eat late night no more, and I'm controlling my blood pressure and my diabetes, my numbers is low, and they keep saying I'm a diabetic, but I'm like, well, while I wear to my stick myself, I'm at 89 and 92, you know, sometimes I'm at 100. It depends if I ate some chocolate cake before. But basically, this program has helped me and changed me. It changed the way I look at, I want to live longer. And I know I have a better chance by now. Taking the medications I take, I'm taking them instead of telling the doctor, yeah, I'm taking them and not just looking at them. I take them because they're helping me. They help me. I can walk from here to there without being tired, and it's just life-changing story. I have more to tell, but I don't have much time, so. But I just appreciate all you guys and that participate, that put into the program, and I'm getting something out of it, and I'm encouraging other people that's obese like myself to pretend to learn to go to some kind of eating habit class or somewhere where they can learn how to change their eating habits, you know, because we have to exercise. It was just a short walk, but just at least a short walk to help you out through the day. And that's all. Thank you guys for having me.
So, Darrell, we want you to live longer also. Just to summarize, we went from 46% to 64%. We have almost 6,000 hypertensive patients. So that's roughly 1,000 patients who are now under control, who weren't under control before. If they had a 17% mortality rate after 2 years, that's 170 people who will be alive 2 years from now. 170 grandparents will see their children graduate and see their children get married, and that's more important than percentages or anything else. These are people, and that's the benefit. And the success is not SAC family success. The success really is the success of this whole program. It's the success of university best practices and everybody sharing their best practices. So, this in conclusion, I want to say this is a team effort. Everyone stepped up, and we knew what we had to do, and we had to come out focused, and we came out aggressive. LeBron James.
So our next section of the agenda, we actually have, we're going to hear more about the Check Change Control Program. We're going to have a team effort from Liz Helms, Mary Ferguson, and Vicki Williams. The partnership that came together for these patients, and looks like they've saved some lives already. I have to say, before Mary gets started, Latanya, when you stood up there, I thought, you know, she looks so much like my mom. You know, just this full of positive energy, middle of her life, parent of young children, and she was walking around with the same kind of numbers you had. She had a worse outcome than you did, though, so thank God you're on medication now. Yes. And that they happened to be at the church when you were there. So let's get some more screenings done, folks. Mary Ferguson, Chief Medical Officer of the Health Services Advisory Group, which is the quality improvement organization designated by the federal government to help improve care in California.
Thank you, Hattie. And thank you, Latanya and Darrell. It's very special presentations. And I know that we all get into healthcare because we want to help patients, right? So sometimes when we're working in the trenches and in our daily working lives, we kind of lost sight of that a lot of times. We think about, well, how do we get the care to be compliant with guidelines? How do we get the care to improve so that we can get the report card to be scoring higher in a higher quartile? We thought about the bonuses and the pay-for-performance incentives that we can get. However, at the end of the day, is the patient. Okay, so the federal government and and everybody at the national level and everybody else here have been talking about patient-centered care, right? So how do we get to that? Is to get the patient at the center of everything that we do, including this, the University of Best Practices. So from now on, we will be inviting patients to attend and participate in our meetings on a monthly basis. And if Darrell and Latanya would love to come, we would love to have you. So as part of that, our work with CMS, we're helping physician practices to improve care. One of the things that physician practices don't really have time or resources to do is to actively engage patients, because that takes time and resources. So we figured out a way by partnering with American Heart Association in their Check, Change, and Control program to invite the patients of Dr. Simon's practices or any practices that we're working with, to invite them to these educational programs that AHA has put through, which you will learn in a minute. And this is the result. So I just want to give that a big applause for American Heart Association and for Liz Helms for helping us with that.
This is our team. And Debbie. I mean, my gosh.
Debbie.
You know, if you look at our logo, it says we're about people, we're about health. And I know we beat that drum all the time to keep the focus on the patient. We're so happy and honored to work with this team and with Right Care. And if we want to talk about someone that personally changed my life, it's Hattie Hanley, because it's never been the same since I've known her. To be able to work with the patients that's my heart. You know, that's my mission. So I don't want to get upset either, but I am so proud of you guys and what you've done and what you've taught me just in the last few weeks. American Heart Association, one of our founding members sits on our steering committee, has been there every day along the way. So we're so honored to have them. And Health Services Advisory Group, which is just an amazing group. So this whole team, Right Care, this whole Right Care team that's come together under this leadership, Dr. Revelo, Dr. Laesch, and everybody here.
AB 54 or 24, whatever it was called. So Joan, yes, you...
Well, 100 years ago when dinosaurs still roamed the earth, I was teaching diabetes at the Med Center, and we did not get reimbursed, and it was always said by Medi-Cal to my own ears personally, well, you're a nurse. Why should we pay you? That's just part of the care, and it went that way for many years. I think one thing that helped us too was knowing that on a national level, they were beginning to certify diabetes educators. And so that bumped it up a level in some of the eyes that beheld it as a profession. So I think, you really have to band together and form coalitions, and perhaps the American Heart Association and some other national organizations that directly are dealing with heart disease and blood pressure. If you can somehow bring them together and start talking and showing that there are genuine education programs, not just fly-by-night tear-off sheets that you're trying to charge for. It's not an easy road, let me tell you. I've spent 30-some years doing this, so, and a lot of it working with Jose. So, but it can be done, but you just need to present a unified program and just keep pushing it.
So we do have all the major health systems
Absolutely, it's all here.
Sacramento Capital Region in this room.
It's all
the community
here.
clinics, Mercy, Sutter, UC Davis, Kaiser. We can figure it out in this room, and I see that Mercy is trying to get in with a comment from the Cardiovascular Center, Joyce.
Sure. I was just going to mention we've had a lot of success to Dr. Revel's point with Covered California being in the emergency room. So patients in our systems right now have a Covered California person in the ED who is then getting them hooked up to systems for that follow-up. So I would encourage, thank through our UC data to check into that. That's been highly effective. And then those of us that are working on outpatient follow-up for chronic disease management, we also can enroll folks, and we're doing, so if we have patients that are referred that are not covered, we connect through that emergency room liaison. They're available to us, and then even when we're out and about doing events, we'll run into patients or people that need to be patients. And so again, we can close that loop, because I think that's the biggest thing. You know, one of the challenges with screening for hypertension out in the community is what if we find somebody who has a really high blood pressure, just as she shared in a community in our health ministry programs and things like that. You know, they struggle with the risk liability pieces. And if one of the things we could share here about what your policies look like, and you know, I'm curious about that, because that comes up time and time again when we're out and about. Obviously, we're logical. You call 911 when somebody has, you know, symptomatic things of that nature. You get them where they need to go. But really, you know, we need to probably address that maybe as a group. That'd be something this group could do. And then I just have a question about the logistics of this magic that you guys had. So from the ability to invite your patients to participate in the program, just how did that happen? I mean, I know you guys have conversations, but you know, identifying patients, who sent out invitations, and you know, just some of that, if you could share, that would be great for the rest of us.
I think
Gil?
Debbie, Debbie came to the office with her crew, and we spoke to our office manager, who is very well connected to the community, and she generated a list of people who she thought would be suitable for this program, and they came to the office, and we spoke to them. Debbie spoke to them, explained what was going on, and that's how they came.
And then the actual classes were at the office?
No, they were at the church.
At the church.
Yeah.
Okay, Macedonia, yeah.
Yeah, I think Dr. Ferguson wanted to make a comment.
I just want to say that that's the reason one of the reasons for existence of this University of Best Practices is to share and problem solve together. You know, each organization may be encountering some problems, and another organization may have a solution. So that's what we do a lot in our work, is to get the community to work together, because after all, you all share the same goals and serving the same patient population. And you don't know that your patients could be going from one system to another, and sometimes ending up in another place. But so anyway, sharing resources is really one of the goals here, and collaborating and working together towards the same goal.
Jose, back to you.
Thank you, Mary. I was wondering if Lily, Shaput, if you wanted to share some comments of what the department.
I had a question, actually. I have a comment and a question.
Oh, great, perfect.
Okay, my comment was in regards to community health worker promotora and the possibility of certification for those entities, and that might be a way to kind of raise the level to maybe something similar to a diabetes health educator that came up in terms of, you know, how do we know what these individuals are doing. So potentially there's the Office of Statewide Health Planning and Development, OSHPA, is looking into the possibility of certifying in some way, shape, or form community health worker promotora with education around high blood pressure treatment training. I had a question actually for Dr. Simon around plank number 6 in terms of the EHR and the registry that's kind of part of that plank. And I was wondering if some of the graphics, the one that you showed from, I think the provider's name was Mia, if that came from that EHR, and whether or not your 9 clinics are connected so you can benchmark and kind of monitor how well the different providers in the clinics are doing. If you wouldn't mind speaking to that.
Yes.
So for those of you who don't know Lily Shaput, she is the stroke leader for the Department of Public Health.
So all the data came from HSAG, and we work with one individual who's our informatics specialist, and he tells us how we're doing. All the clinics are networked, and with one system, and we just run reports, and the data come from him. Did I answer your question?
I think so, yeah, okay, so they're all networked, all 9, and you benchmark and you quarterly provide providers information around?
I didn't have the information until just recently. So I provided them the information a few weeks ago, giving them the range from the low to the high, and giving them the average. I didn't want to tell each one. Now, our 4 highest performers each got a gift for me. I gave them a lime tree. A lime tree, yeah. Yes.
Did the provider that wasn't interested because their perceptives changed? No, I didn't mean what sort of gift, but I mean, has he seen the data? I mean, I wonder if
He saw the data, and in the spectrum of early adapter, innovator, and laggard, he's at the right end of that spectrum.
So if I can add, so Health Services Advisory Group has a team that has expertise in EHR. And so we go to each physician offices who voluntarily work with us, because there's no mandate for any physician practice to work with us, right? But for those who want to work with us, we will go in and help them pull their data, help them prepare data feedback reports, help them see which patients have been missing what. So diabetic patients who did not come in for hemoglobin A1C for a year, or certain parameters that we work with the physician to set that up and pull the data for them. And teach their office staff to do that on an ongoing basis, so that it's empowering them and so that they can be self-sustainable.
And the other thing I'll mention is that we've supported some of the community clinics in San Diego, Los Angeles, and also in Colorado and the DC metro area who are implementing population health tools such as I2I tracks and other types of technologies that wrap around their electronic medical records. And by doing so, they've been able to implement report and scorecards for their physicians, which they've also been able to just pull from the server. So what I mean by that is our San Diego clinic actually developed a tracking tool for the diabetic patients for HbA1c by panel, looking at that data, looking at blood pressure, looking at prescription rates. When we were working with a community health center, a federally qualified health center in the greater Virginia area, they were starting to implement I2I, and they're like, what do we do? And I was like, well, instead of recreating this, you can actually speak to I2I and get the clinic in San Diego to upload their report that they customize into the server. You can download it. It builds a lot of technical assistance between federally qualified health centers that may never have actually spoken to each other because they're on opposite sides of the coast. And we're actually starting to build a practice there where people are connecting with one another to look at that innovation. What's really interesting, as many of you all know, is you see one FQHC, you've only seen one FQHC, right? But you also see a lot of similarities in terms of the populations that they're serving, not only those that are Medicaid, but the uninsured, and interestingly enough, in terms of language and health literacy. So Northern Virginia area has a large number of immigrants who are coming from Central America, as well similarly to San Diego, where they may be predominantly Mexican. But is there an opportunity to leverage the language tools that are being utilized and the literacy that's being developed without having to recreate that all over the week, all the time?
Thank you, Coralie. So Coralie has not been with us before. She's from Kaiser National Community Benefits. We'd love to have you with us on a regular basis if you can be. We meet every second Monday of the month.
I'm already in San Diego.
I have one quick comment, if I may. I was impressed with the ease with which Gil enrolled patients in these initiatives. My hypothesis would be that was a function of his clinic being very much embedded in the local community. If you would graph relationships between the MAs and patients and family members and church associations, I think you'd find a close association. And if that hypothesis is true, it was a function of being closely and intimately embedded in the community, then it would behoove other organizations where they don't have that pre-existing embeddedness in the community, where people drive in, don't know people in the neighborhood, it seems impersonal. I've been involved in projects where it was just that. It seemed a big organization, it was impersonal, there were no interpersonal connections. In those situations, it might behoove those organizations to invest time and energy and money in becoming more closely embedded in the community, simply to have better relationships, more close cooperation and participation in the future.
Thank you, Warren. And I just want to remind people here, those who are eligible for CME, please fill out the evaluation form. The second page is the CME educational credit form. So please completely fill it out legibly, accurately, and we will be sending you the CME certificate in a few days.
Thank you, Mary. Well, we've come to the end of our time, and I wanted to, first of all, thank Gil again, and the team, and thank the American Heart Association, and thank Darrell and Latoya's gone, but wanted to also thank you for participating and remind you that July 14th is our next Right Care, and at that time, Dr. Winston Wong from Kaiser is going to be talking to us about Kaiser's approach to reducing disparities in blood pressure control. And Chloe Bird from RAND will be talking about women's cardiovascular disease treatment disparities. And again, thank you for your time, and have a great rest of the afternoon.
We will have one more Heart Association video on the check change control program, and you're all welcome to stay and see it. I think it's really fabulous. And I think we have to figure out how to better use those materials that are created by the various institutions, for instance, HealthNet, the Heart Association, etc., instead of reinventing the wheel. How do we catalog the available resources and get them into the hands of patients? I would love to see the patient-level information that Martha Garrity has developed be spread broadly to the patients, and it won't happen one health plan at a time, so this collaboration is very helpful. Are we ready with the video?
Not only did he have a heart attack, but he lingered for a week.
I've done so many funerals. I've been to ICUs.
And so he wasn't taking the medication that he knew he should be taking because he was just too busy. I became involved in the program because of the death of my brother. It was sudden, and at the time we did not realize that he was non-compliant with his medication. Because of that, one of my friends, Joyce Watson, said, you know, there's this program with the Heart Association. So I went to the meeting, and this is how I got involved and brought it back to our congregation.
This I thought would be something that I could bring to my congregation that would bring awareness to those that may be going through some similar symptoms, but it would be something that would be preventative as well as proactive in their own lifestyle.
From then on, we just hit the floor running.
The American Heart Association furnished us with trainers and people who lecture.
We should never underestimate the importance of self-empowerment and the ability for a patient to feel in control while trying to take care of their health.
We provided every church with at least 2 blood pressure monitors and a scale.
And this program here helped me show me how to manage it, what I needed to do.
Since I've been on the program, my blood pressure has gone tremendously down with exercise and proper diet.
I walked the other day and I felt so good when I walked my dog. When I came back, he was tired.
and I lost 7 pounds the first week we started.
I've lost 18.4 pounds.
My daughter and I get together and we join the gym together. So we're supporting one another.
In addition to that, I've started to implement things for my daughter. So you're no longer couch potatoes.
With the exercise that I've been increasing with the program and being more cognizant about my diet, my blood pressure has gone back down.
Since I've been on it, I have been taking off 1 blood pressure.
And I lost 10 pounds. I haven't been in this dressing.
Right now, in this room today, something's happening. Something's happening. Part 360, the Wellness Ministry, we love each and every one.
Thanks, everybody, for being here. We'll see you on July 14th.
Great, how are you?
And thank you, Darrell, especially for being with us.
I'm not going to say anything more. It's just, we have a lot of work to do, but haven't we gotten started in a great way?
I just want to just thank everyone for this opportunity. I've been with the American Heart Association for 6 years and always working in the community, specifically the African American community. And as you know, we've got a lot of work to do in the community, but we're seeing progress from the day that I started 6 years ago to where I'm at now. We've really, people are starting to have those conversations around health, have those conversations around knowing their numbers, and being more educated about what they're doing. And so I'm very encouraged, and so participating in this program is always great because you love it when you have those moments when the light bulb goes off. And I know when I'm always in the community, I want to think about your motivation, who you're doing this for. You want to live longer, you want to see your children graduate, you want to see your grandchildren, you want to walk your daughter down the aisle, etc. And so you try to put that motivation into everyone. And we have to come at them with the hard facts. It's not, I always say every time heart disease and stroke is not a sexy topic, it's not. But it's something that we do need to talk about. We need to talk about it in our families, out in the community. So we had a wonderful group who was really open just to learning, and that's always great. So we're going to continue the work that we're doing. I mainly focus in the Bay Area. I work a lot in San Francisco, Oakland, and we're doing some great things there around our check change control. From the American Heart Association standpoint, we're on our mission for our 2020 goal to get 20% of Americans heart healthy, as well as reducing mortality and morbidity by 20%. So we've got a lot of work to do, but like you said, we've got a great start to it. We're just getting communities more into preventative is what we're looking for, instead of everyone being reactionary. So we really want to just put that out there that everyone can be an active participant when it comes to their heart health. Thank you.
Video, please. So there are a lot of resources that are available, and we need to figure out how to use them more effectively in the community, take them out into the medical groups, etc. And this is one of the great resources for the patient activation piece.
Had I not been involved in this check change control program, I have no doubt in my mind that I probably would have had a stroke this year. Based on the question from one of the ladies, hey, would you like your blood pressure taken? Sure, I figured I'm healthy, I'm exercising, I've lost about 25 pounds, so it's gonna be great. I was shocked when the reading was 174/96.
so I called my mom and told her I'm in this class, it's gonna be at our church, and I want you to come out too because you've had a stroke and I want you to be around, so we gotta get a handle on this.
The difference between what the doctors did and being in this environment is that you're with people who have the same type of problems that you have. You have people that are teaching you through videos, they're teaching you with the examples, they're doing hands-on.
So if you have a community of other people where you don't feel like I'm by myself, I'm overwhelmed, so you can encourage one another.
There's one person in the class, you can see since he's been doing the class, he dropped some weight. And I made sure I told him, "Michelle, you lost some weight." People need some encouragement sometimes to keep on the right track.
When I go to my doctor office now, I know how to speak to him. It's about me. It's not about the doctor. It's about me.
I would say I was a functioning illiterate when it came to managing my heart health. Communicating with my doctor now, I think I am much more a participant in the discussion as opposed to it being a one-way conversation where the doctor is telling me this is what you need to do.
It was brought to my attention because of the nurses here taking my blood pressure that perhaps I needed to go see my doctor and change medication. So I've done that while I'm here.
That changed all my eating habits since I've been here, which is good, a low salt intake.
The biggest change is my blood pressure is going down. So that's a good thing.
I've been walking a lot more than I was before I started getting in this class. My blood pressure has came way down.
Built my self-esteem and more so as far as motivation. This was a very motivation class, and I really enjoyed that part about it.
This program is excellent for the community because it didn't matter like what your social background was. You just needed to come out here if you had a problem that you wanted to, really learn more about and have some insight as to what you needed to do to take care of it.
I would just say to the doctors and the administrators and everyone who's involved in bringing this to the communities that this program is worth every single penny that they've invested. And I thank you for what it's done for my family.
Next step's Hollywood, guys.
Okay, well, Carla gets that teed up. Next person to come up, we're gonna have Warren Barnes come up and give us a little bit of information about some practice support that's available. And Warren, he serves several functions. He is the pastor of Grace Presbyterian Church here in Sacramento. He's also a regulatory consultant at UC Berkeley School of Public Health and is an adjunct faculty for health law at the University of Southern California. So we're honored to have him as part of this group.
And we can't stop with that, because I have to say, he was the right arm that started the Right Care Initiative. And before that, he helped to write many of the patient protection components of the Knox-Keene Act that governs managed care for the state. So Warren is a bit of a legend, and you're very lucky to know him.
When we started the Right Care Initiative, Hattie and I would take turns bugging each other if either of us happened to get cold feet, which happened on very rare occasions. I must say that while I was listening to Gil's presentation, which was incredibly impressive, my mind did wander for just 1 nanosecond. Because Gil embodies what I think is probably Jim Collins' most famous quotation, and I will try to paraphrase at least. Greatness is not a function of your circumstances. Greatness is a function of your determination and your discipline. I thought you embodied that marvelously, Gil. You might have even written some of Jim Collins' stuff and maybe he plagiarized it, I don't know. What I'd like to do is share information about a terrific opportunity for small physician offices, small provider sites. The University of Berkeley, UC Berkeley School of Public Health is submitting a proposal to ARC that's going to focus on solo practices, small offices with lead clinicians, could be doctor, could be nurse practitioner or PA, of not more than 10, and frankly not a high degree of sophistication in quality assurance. The goal that ARC has is to accelerate the dissemination and the implementation of the core findings into primary care practices. So it's the primary care practices that we're interested in. We will have 3 arms in this project. We'll enroll 300 practices. About a third of them will go into one arm, which is collaborative. They'll have a learning collaborative, and that will be a new thing in their life. And one of the other arms will have technical consultation, one-to-one, an expert consulting with the physician's office, and that will be their change. And then the third arm will be a combination of the two. Learning collaborative plus technical consultation. And the consultation on that arm, the learning collaborative, the other arm, the two together, they will all focus on the ABCs. That is aspirin and blood pressure and cholesterol, and some would add the S, which would be smoking cessation. All 3 arms will have what I would characterize as a vital community component, which will involve real people. I should say real people who are not also clinicians. Reaching out into the community with a big focus on disparities, because I think we are likely to find that many of the people in one-doc practices, small offices, are more likely to be more grassrootsy than many of the people who are in large medical groups. And the large medical groups do have, for the most part, at least the opportunity to have all the resources for themselves to propel themselves forward. So if you have any questions about that, I will be leaving in about 5 seconds from the podium. That Ruby Lynn, my associate here at UC Berkeley, may be asking some of you for letters of support. We want all of your support, but we need to get letters from some of you. I've been doing some of those. She's going to pick up on those for me. And Addie is also a good resource, and Mary is also a good resource. And is anybody else wanting to be a good resource here? If you have any questions, I'll be happy to take them and divert them to either Ruby or Mary or Addie. We have 30 seconds left. I'm the official timer, and I get the time myself, and I don't have any more to say. Any questions? If not, thank you very much.
Thank you. This has been a great discussion, and again, I want to underline the accolades that Warren just did for Sacramento family and Dr. Simon taking this on, and HSAG facilitating, as well as the American Heart Association, is a great example of the kind of work that we should be doing, and we feel excited that RightCare played a big role in this. So, what we want to do now is really open it up. We actually have our timer has done a great job. Thank you, Warren. I appreciate it. And we actually have our head of schedule, but we had thrown out a challenge at the very beginning, and you saw a great example of the use of these portions of this program, Measure Up, Pressure Down, that Dr. Laesch has provided to us. And so one of the things we wanted to have is an action discussion, have the opportunity for you to kind of do a Q&A specifically about any of the pieces you've seen today, and then really about the challenge that we laid out. How can we use this or other programs similar to this to be able to begin to address and improve blood pressure control in this community. And eventually, hopefully with the work that we're doing with this grant, go beyond just blood pressure to really result in some final major improvements in cardiovascular risk reduction for the capital region. So we'd like to open it up for questions now, and we'll be happy to try to answer them or direct it at Dr. Simon in this program. Or if you have any comments, and Lisa, I saw your hand raised up there.
Yes. Well, I just had one question. I'm familiar with Dr. Simon's practice and work that we've done in Medi-Cal. I think certainly can everyone hear me?
No.
Certainly he's an exception in his kind of commitment to his patients, but not an exception in the very scarce resources available to particularly Medi-Cal practices. So my question was, what kinds of resources are these physician practices getting to trying to keep this initiative moving forward? And has that been something that has come up as a major problem in implementation?
Great question. Would HSAC, would you like to kind of talk about some of the resources that HSAC made available, and then American Heart Association has some resources, but UB.
Well, as a quality improvement organization for California, we've been tasked to promote the Million Hearts campaign with the small and medium-sized practices in the past 3 years. We have a team that consists of the Sacramento office people here as well. We have a team that has been helping the physician practices implement the electronic medical records, and for those who are using EHR, we are helping them to use the functionalities of EHR for care management. And along with that, we work with them on a redesign of the workflow in the office and teaching the physicians how to be more efficient and using team-based care and translating clinical guidelines into practice. I don't know if that's enough. We use the chronic care model, so we not only activate the provider, the physician office, we also activate the patients. And on the patient activation piece, we're partnering with AMGA, as you have heard. That's one of the things that we do in terms of patient education.
I would say on a regular basis, we're only just a phone call away. So if there's something that you are looking to do or want to partner, primarily, I don't necessarily work at a study base. I usually go into the community. I'm at a church, I'm at a workplace, wherever the case may be. But from a medical standpoint, if there's a program that you would like to implement, or if there's brochures, resources, any of the tools that we have are more than welcome to share. Here, there's an office in the Sacramento area. We're on Old Street. Like I said, I'm based in Oakland, but I'm more than happy to be involved in anything where that's involved, patients are involved.
And I guess my question was largely motivated by, I think a lot of physicians are very challenged by the idea of, this sounds like a great program, but it's one more thing that I have to do. How am I going to find the resources to retrain my MAs or make some of the other changes in conjunction with this program? So I was sort of curious about those sorts of practical supports available to physicians, whether that's stipends, whether that's kind of one-on-one coaching and training. That was the piece I was...
Well, I know and Dr. Simon will speak on it more, when we did this program, we knew that that would be the case. So our goal was to maybe have one liaison, but at the same time, we would take everything over. We weren't interested in adding anything more on anyone's plate because we already know it's full. So when we came in here, we tried to make sure we had the resources that we would, give us the patience, and then we would go from there. I'll let Dr. Simon speak more.
So you're right, the change control program is very intensive and requires a lot of resources, which we didn't have. But luckily, we have partners. We have people in the community who have the same goals that we do. As far as the Measure of Pressure Down program was concerned, that was very resource limited. All we needed was just to make a decision. And the decision was, this can work. And if it can be done, why not do it? It took seeing that Kaiser did it. It took seeing that others could do it. And I'm a pretty competitive person. And if they can do it, why can't I do it? And I didn't really see it as being our achievement. I saw it as being the kind of a group achievement. And I wanted to take advantage of what the group had accomplished. So it did take time, but it ends up saving time and saving money. These are 160 people now who will not be stroke victims and not have heart attacks. And so it's an investment, but it's a very good investment.
I might just add that I've been working in, as Dr. Simon said earlier, 3 other communities. One in San Diego with the African American community, one in LA with the Asian, and one in LA with the Latino. And what I have seen as a success factor is that you have to have a group of community leaders that will take this project and make it sustainable. We did not have that in Sacramento. We did not have it in the 2LA, but we have it in San Diego. So I think as you all talk about this initiative, what you want to do in this community to make a difference, what I have found in San Diego is you have to get community leaders who are going to take this forward, look for funding, look for sustainability, and make a difference. And I know that's one of the greatest lessons that we've learned at HSAG doing these 4 programs in different communities.
Could you give some examples of what community leaders who you approached?
The community leaders in San Diego were already formed. They were a combination of African American leaders and Latino, specifically in Southeast San Diego. They had come together because, frankly, they were tired of seeing their friends, their fathers, their wives drop dead of heart attacks at the age of 50. They were tired of it. And so, as we all know, the barbershop campaigns that started, they've been successful in San Diego. But what they did is they came together, and there's probably about 30 leaders who meet monthly to discuss this. And so what HSAG is doing is the Check Change Control program in San Diego, and we're also doing a report on the messaging of the Right Care Initiative to say, if we have a campaign in Southeast San Diego, can we make a difference by doing Check Change Control, and can we make a difference by doing messaging? Is one working better than the other? Are both of them working, or are both of them failing? And so that information is going to be presented back in July to this Community Advisory Committee. And they are going to be taking that information and applying for future funding from CMS. They want to do it on their own. So I really applaud the effort that they're doing by taking that kind of position. And I think they're going to be very successful at it. But they're not going to take programs that don't work. So they're really going to engage their providers. They're really going to engage their leaders, and they will make a difference.
Martha Garrity.
Hi, I'm with HealthNet. I have a couple comments. First of all, Pam addressed the resources, and I've been very passionate this last 6 months of putting together a patient toolkit. And I did it basically on HealthNet's time, but for the community. And it's written at a patient level. It's called Healthy Women, Healthy Hearts, Healthy Lives. And it's really the basics of what heart disease is and what to expect when you have heart disease. My personal experience with my mother is my sisters and I all have over 100 years of experience in healthcare at really high levels. Sister's a social service, I'm a gerontologist. My other sisters work at UCSF and UC Davis, and when we were confronted with the heart disease, we didn't know where to go. And I worked with my mother before she died on what did that test feel like? What was that experience like? And putting together a toolkit called Healthy Hearts, Healthy Lives for the patient in 6th grade level or below language, plain language, that was easy to understand so that when someone is working to prevent heart disease or actually has heart disease, they know the steps they're going to go through and the path that they're going to follow and the journey that they're going to follow as a family. So I'm very excited because part of it is going to print this month, and that's the prevention component. I also developed 5 booklets on disease management, which we're still working on printing, a journal and a DVD about the importance of physical activity and nutrition in heart health. So very, very proud of that. It's been my passion, and I hope to share it with you guys in the next month or two, but that's really important. On another level, in terms of community engagement, we normally put together frontline staff and provider forums. Dr. Simon's been very involved with these programs. I have flyers, there's one tomorrow night, and it's on cultural linguistics and also on motivational interviewing, so that ties into the topic. Finally, HealthNet statewide, we're doing a Know Your Numbers program. And here in Sacramento, I've geo-mapped all my members that have diabetes and are not taking care of their A1Cs. And we're making outreach phone calls to them and inviting them to a forum to get checked, to get all their screenings checked, and then a follow-up phone call to see if they made it to the provider. So we're working with Dr. Simon's group, with River City, with many of our providers based on this list. And I found that it's Russian, Latino, and African American. So I have to do 3 programs in 3 different geographic zip codes. But it's starting to work. So those are some innovative practices that we at a local level are doing. Also the Healthy Sacramento Coalition. Everyone in this room should know about the Healthy Sacramento Coalition and what's going on. And Dr. Darrell is actually a leader in that, as well as many of the partners here. So I think Sacramento has a lot of potential to do a lot in the community. We already have, and I just wanted to make that comment.
Kim Buss has a comment.
I just have a quick question. As I'm sitting here listening to people talk about the difficulty getting hypertension education done for patients, I think about the diabetes model, where diabetes education is reimbursed by insurance for patients with the diagnosis of diabetes. And I'm wondering if anybody knows whether there's been any movement towards insurance companies paying for high blood pressure education as part of the diagnosis of hypertension. It seems like the model of diabetes education has some tremendous advantages. Certainly allows for patients to have their education paid for by their insurance. And so does anybody know if there's any kind of discussion about having high blood pressure education reimbursable by insurance?
This is inside, Kim. This was a real significant political movement that occurred back in the late 90s or mid-90s for SB 54 or 24. It was the diabetes community coming together and actively promoting this bill that was aimed at the Department of Managed Health Care for reimbursing for diabetes, specifically education. So as far as I know, there hasn't been anything similar in some of the other chronic diseases.
It seems that hypertension clearly affects, if not the same, more numbers of patients. And since the information seems to be so prevalent about the importance of control, that maybe that would be a place that the hypertension community could move towards as a possibility.
I can check with our advocacy efforts and see if maybe there's something that they're working on, but to my knowledge, there's nothing we're working on right now.
Let me just understand, is the source of your question that you believe that patients who have coverage are not getting the education that they need on blood pressure control?
Well, that blood pressure education by a health educator is not reimbursed by a lot of insurances, many insurances, PPO insurances. So, for capitated patients, it's a decision of a medical group or whatever the HMO is. But for PPO insurances, that health education, as far as I know, for hypertension is not a covered benefit.
So we do have a couple of insurance executives in the room. Mike, could you address this from United, please?
Well, I can address it from United from the Medicaid side. So I do Western Region for United Healthcare. And you know, that's a great question, and I'll tell you, there's things happening in other states that are pretty amazing when it comes to Medicaid or the Medi-Cal. New Mexico now reimburses encounterable experiences for community health workers and promotorists who are actually going out and doing education, but not just for hypertension, for many other aspects. And I've talked to Dr. Kohatz, I think you had to leave.
Yeah, Dr. Kohatz had to leave, unfortunately, from
And we've had these
Medi-Cal
discussions about how this would be really great for California if we could start doing what New Mexico is doing today, and it is being done in New Mexico. We'd like to bring it here, and that's a discussion, and I've made them aware of it, and it's something that certainly would help out, and that would address that from a Medicaid perspective. But in the commercial side, I can't really speak to that, but I'll talk to Jeff Mason or
Well, my understanding is commercial side, I don't think it's covered by any commercial PPOs, but I don't know if that's the case. That's just my impression.
You know, in terms of a requirement to cover it, which is really what SB 54 or whatever it was called when we initially worked on it, because I was part of the group that worked on it, it was specifically requiring it to be reimbursable. So there is no such action that I know of for any of the other chronic diseases, and not just hypertension, but you know, cancer or some of the other things that where there just hasn't been that level of activity, the level of advocacy to promote it.
So Pat Zrelak with UC Davis stroke program is with us right now, and she had pointed out to me a very sad situation whereby patients come in with a TIA to the emergency room, and they really need that blood pressure education. They may not have insurance, and then they go back out into the community with a very high risk of going on to stroke. Pat, could you talk about that a little bit, and what you know might be going on in the Sacramento region about this?
I can't remember our conversation, but I think it's about not just TIAs, but I think all stroke patients, when they come into the hospital, they don't have insurance. It's a problem. We can get them on their meds, we can give them recommendations, but if they don't have primary care physicians in the community, it's going to be that long-term care it's going to prevent them from having an event. And those TIA patients, as you know, are very high risk. So, and many of them, if they're, especially in the first 2 weeks, their risk is highest, especially in those first couple of days. So we don't exactly just let them out of the emergency room. We I think everybody in town will work those patients up to make sure that they're safe. But they do need to get their blood pressure taken care of, and their lipids and their diabetes, and taken care of. It's very hard because there's not enough primary care physicians in the community, and especially in an acute, in your emergency department type setting, it's hard to actually get them connected as well. So there's that kind of that case management part that's missing.
Of course, the piece is that if they don't have insurance, you know, and if they're eligible, somehow, some way, we've got to figure out if we can get over to California to work with them, because that's going to be a key issue in terms of the follow-up with primary care doctors and other specialists. Can I just mention, I know Lisa is going to get ready. So Lisa, I think to answer your question more specifically, we think this is a forum that's going to help create or at least facilitate some of those resources, because there really isn't another place to identify where are those resources happening. Particularly, I think what's happening is that you know, we're wanting to share best practices. So if there is a physician organization or a health system, because we are some major health systems out here that have found a solution and are working, for example, on natural pressure down, like Sutter, and if we are able to, you know, facilitate that happening within our integrated system, and we can share that under this specific growth to say this is what worked and this is what didn't work, and so that's one other way to help facilitate you for the integrated groups. And then, you know, we have moved beyond, in my understanding, San Diego and LA, because we have included the community with the community clinics and the county. We've also asked the county to participate, although they haven't come forward as much. But it's really to lay the groundwork for Capital Region Right Care to be one place where this could happen And this very same discussion to be a way to reach out not only to the other physician organizations, but to the community clinics and the other physicians and other systems that are out there that are trying to find solutions for this. So we really hopefully will continue to use this forum that we meet monthly to be a way to address this. I know Joan, and by the way, I have to say something because Joan and I worked, she was the first president of the Diabetes Coalition in California, and she did some yeoman's work to put this together, and I was the second president of the coalition. And so we worked